Try again, Claire, Louise, Joe, can you hear us? We had a glitch in the room, so would one of you?
Yes, we can hear you now.
Yes, we can hear you now. Thank you.
Let me just recap on the area of those, with apologies for that technical glitch. We have now resumed. We're going to move on to 6.3, which is the Grampian vaccination and immunisation report. I would just advising colleagues that we are going back to the initial chapter papers that came out about a week ago. This is on pages 69 to 188. Welcome to Joe and Claire, who are the Skirling workers behind this. And if there's anything you'd like to say by introduction, please go ahead.
Thank you very much. So good morning, everybody. For those who haven't met me before, my name is Claire Louise Walker, known as Claire, and I'm the immunisation coordinator for NHS Grampian. The report you have in front of you is a Once for Grampian report. It covers the whole of Grampian. In the papers that we have given you, we have tried to signpost and pick out those areas of particular interest to an Aberdeen City audience. However, the remainder of the report, much of the remainder of the report is also of use regarding context to how the vaccination programmes in Grampian run and our interface with national bodies. I'll just make a couple of brief remarks. One is about how well received some of the innovation that is happening within Aberdeen City is received nationally. So, for example, last year at the inaugural Scottish Vaccination Immunisation Programme conference in June, a team from Aberdeen City were present and were presenting their work on making every opportunity count and the whole kind of holistic approach that the hub really demonstrates. And just recently, yesterday, I had a communication from one of the senior medical officers in the Scottish Government asking for further information about some of the work that you had been doing with regard to employing newly graduated nurses within the vaccination services and how that was seen as a very positive step going forwards. Generally speaking, the team in Aberdeen City are very innovative, and I think that can be seen in the uptake data that you have from them. And I appreciate that this isn't the only opportunity throughout the year you have to see uptake data from them. Generally speaking, you can see that in common with many cities, some of the uptake in City is lower than in other parts of Grampian, but is broadly comparable with the kind of patterns you would see in a city environment. So, for example, you have a more transient population. You tend to have a population that has more people who don't speak English as their first language. You have particular problems with areas of the city where there is more socioeconomic deprivation. That's not to say that the areas like that aren't seen in other parts of Grampian, but they do tend to be clustered in city environments such as Aberdeen City. The other thing I just wanted to pick out from the annual report is that for the first time this year, this is our third report, but we've expanded a section on finance, and the reason for this is the 25-26 financial year was the first year that the portion of the funding that comes directly via SVIP, the Scottish Vaccination and Immunisation Programme, was baselined to the board. So we had the situation where it was baselined to the board, but also we had the first time that Scottish Government had asked us to absorb the costs of new programmes within the within that baselining. So that was something new for the year that this report covers, and in response to that, we did an expanded finance section trying to explain where the different funding streams come from, because it is a quite complicated financial landscape for vaccinations. I imagine people have lots of questions, so I don't really want to pick out anything else specific at this moment. But if there's anything that people would like to ask about or would like to hear more about, very happy to help.
You both, are there any questions or comments? Vicky?
Yeah, thank you. Yeah, I think it's a very cohesive report, but it's about 110 pages long, and unfortunately there is only one mention of carer in the whole report. On page 80, in the equity part of the report, it does say carers, but it doesn't actually specifically mention that it is unpaid carers either. So yeah, I just wanted to comment that I think that you know, carers do take up a substantial amount of the population for, you know, Grampian city specifically as well. And I think that it would have been a bit nicer to have seen a little bit more in relation to that side of the population.
No, thank you very much for bringing that up. That's a very good point. Thank you. We'll take that forward.
To Richie and then Mark.
Yeah, thanks for the paper. Lots of really good information and what being done. So again, thanks for the team. Question was just around, and you did mention where the take up was slightly lower, whether that be in terms of socioeconomic or particular age groups or particular types of groups. I wondered if there was any feedback from those groups in particular that might inform how we might improve take up in future.
So I'll make some general remarks, and then I think I might turn to Caroline Anderson, who's present in the meeting too, for perhaps some more details. Certainly for this coming year, we have plans around some engagement work with members of particular communities where we know our uptake is particularly low, and that's an across Grampian initiative. So we're looking at Polish communities and African Black African communities, because over a period of years we've seen that their uptake is lower across a number of vaccination programs. And what we're doing is we're looking at, in a similar way to screening did a couple of years ago, looking at what kind of information, what kind of framing of the benefits of vaccination means the most to those communities, and then changing our communications approach based on that. But I know there's a lot of outreach work goes on locally, so I'll turn to Caroline. Thank you.
Right, thanks. Yes, I can take you through some of the work that we currently do to try and increase our uptake. So we have weekend clinics that we have open on a Saturday within the vaccination wellbeing hub, and also allow drop-ins at those clinics. And that's just to support working families who again can be a lower uptake. We have got mobile and pop-up vaccination clinics that we hold in some of our lower uptake areas, and we use the data to identify the areas that we'll go out to. Looking at the wider vaccination programme, so the school vaccination programme, we've changed our model of delivery, so we're now visiting schools for a whole week instead of 3 separate times a year, going in for a day or two at a time, and that has actually helped increase uptake. Pupils that have maybe been absent from school are able to come in later on in the week, or children that have been a bit more anxious at the beginning of the week, the nurse has been able to work with them and get them to come back later on in the week. We're also going out and looking at more engagement in the communities, so we're going out to schools, we're going out to different community events and preschool, nurseries, early engagement, just to do engagement promotions. We've got a teddy bear hospital where our nurses are going out and providing more information about vaccines to nurseries and community groups, and also working with Home Start in the future as well. Yeah, that's some of the work that that we're doing at the moment to try and increase our uptake.
Sue, can I maybe just add one, Caroline? Why don't you say a wee bit about sort of fun events where we've invited families in and had really good success with people who had missed a lot of appointments before?
Yeah, so we've had our family health and well-being events, and that's where we're working with our community partners. So it's an event that will come in. We'll have lots of different voluntary organisations. It's an opportunity to speak to families about vaccinations, but we're also inviting children who have regularly not been brought to their appointments to come into that environment where there's a bit of play, a bit of more of a fun environment to come in and address their more wider health and well-being, as well as vaccinations.
And some of those people, some of those children had missed 20 plus appointments. That's kind of a measure of success of what the team were trying to do.
Yeah, I was just saying that sounds like a really good package of activities. Thank you.
And thanks, Caroline. You've really helped to bring some of that to life as to what yourself and the team are doing. So thank you for that. We'll go to Mark and then Martin.
Thank you very much for the report. I had the pleasure of having this brought to Area Clinical Forum, which I chair last week, so it was good to see it mobilised there. The report itself is a fantastic read. It's long, but there's a good read to it. I think one of the comments that I'm making about is the importance of the inequities that Richie brought up, but also about the fact that if you look at the cost effectiveness of vaccination within the transformational work, you know, if you look at something like human papillomavirus vaccination for our teenagers, the ongoing effects of that, and when I work in a specialty that deals with oral cancer, the 25% increase in oral cancer by HPV, if we can reduce that, the amount of finance that we require to treat those patients subsequently is vast amounts of resources to treat that. And it just goes to show that vaccination is one of the most cost-effective methods of our prevention strategy, and it should be the core of where we sit, I think. So I think I just welcome the paper and wholeheartedly support it.
Thank you, Martin. I'm going to come to John and Sandra online, and then I'll come to Amanda and Ken, just so you know. Martin.
Okay, thank you, Chair. Yes, I found this a really excellent and quite exciting read. There's so much going on, and I was very pleased to hear about the very positive results from targeted work in schools. So there's mention there of the pilot of going to schools. That's been successful. So that's going to expand. I think that's a very good way of reaching your audience. There is highlighted the inequalities risk and the risks of uptake gaps growing in particularly vulnerable groups, and they've been identified. So, you know, it would be useful just to hear if there's very tailored action proposed to reach out to those groups which might feel excluded or marginalised, and which need that extra reach. So kind of, I think, so it'd be useful just to hear back on that first of all. Thank you, and then I've got a second.
Yeah, so again, I'll say something and then think Caroline might want to come in. So as I said before, one of the things we're doing is we're looking at a particular emphasis on the Polish and the Black African communities from our ethnicity profile, where we have lower uptake. Alongside that work, there's a parallel piece of work going on about people who live in those socioeconomically more socioeconomically deprived areas, and it's the same kind of ask really. It's that kind of information gathering about when you think about vaccination, you know, what do you hear when you see our the materials and the kind of advertising that goes out and marketing of vaccinations? What does that mean to you? What would be more meaningful to you and for other people from your communities, so that we can extend that reach on more of a population level? But I'll bring Caroline in at this point.
Thank you. Yeah, so some of the work that we've been doing around some of our vulnerable groups, so those with substance misuse, we've been working closely with our substance misuse service and also with alcohol and drugs action in Aberdeen. So we've now got vaccinators that attend ADA twice weekly to support around vaccinations and promoting. We've also arranged for some of the substance misuse nurses to become peer vaccinators. So again, when they're out seeing patients around other things, they can be discussing vaccinations and undertaking them. We've also done some work with the asylum seeker looked after children. So we had a recent piece of work where we worked alongside the TB nurses and also social care teams to bring these adolescents in for a joint initiative, and we had 44 children turned up at that event, and we've held a follow-up since and had a really high attendance rate for that as well. We are also using learning disability health checks, so our team also undertake the learning disability health checks, and during those checks discuss vaccinations, and if we can do any opportunistic vaccinations at the time, we do that. And we also use community appointment days. So every time we've got a community appointment day, we'll have a vaccination team along at those events. Again, speaking to people about vaccinations and also undertaking opportunistic vaccinations. So that's a few of the things that we're doing around some of that groups.
Thank you very much. It was because vaccination is part of our general community cohesion. We all rely on the very important preventative work that goes on through this very complex and wide-ranging vaccination program. So that's really reassuring. But I've got a second question, and it may be related to what I just said. There has been the incidence of measles in the Northeast, first case since 2014, and that goes again, that really does conflict with the information we're having about the increase in MMRV and the reach out through the vaccination program. So is it possible to get an understanding of what's happening out there? I really appreciate.
Yes, sorry, your microphone was slightly in and out, but I think you were asking about MMR and MMRV and the fact that we're saying this is coming in, but we're getting outbreaks of measles in the Northeast. Is that correct?
That's correct, yes.
Right, thank you. I obviously can't give too many details about the cases of measles in the Northeast. However, I can say that they were that they weren't linked, and I can say that they were in adults, not in children. Essentially, you know, what's in the report about bringing forward the second measles vaccination earlier with the MMRV. We are expecting that to improve uptake. That's one of the reasons for doing it, but that protects that's protecting the childhood population, and obviously they will keep being protected as they grow. But we do have have a bit of an information gap when it comes to adults. So I can't tell you how many adults in the Grampian area today have had 2 of those MMR vaccinations. Now we're kind of picking around the edges of that. So if you come and talk to us about travel vaccinations, we will also talk to you about the MMR. When children, when parents bring children for vaccination, there's that opportunity there. Are you yourself vaccinated? So I think going forward for the future, I think we're going to be in a very good position. I think we do have a gap. We do have a gap with adults because we don't have that kind of data easily available to us about who needs vaccinating, because the measles offer is practically a lifelong offer. So if there's anybody sitting around the table who hasn't had 2 vaccines containing measles, please contact our call centre. We'll be very happy to make you an appointment.
Thank you very much. I'm just very conscious that vaccination is a social responsibility, and what we're looking at through these news stories is a reversal of the direction in which we've been travelling and which we should be continuing to travel. We should have eradicated measles in the North East. So any further focused attention on reaching out to the adult population and encouraging and sharing information and explaining why it's necessary. I think that would be very helpful, because we don't want to see those numbers increasing. Thank you.
Thank you.
Thanks, Martin. I'm going to go to the folks online. So John first.
Thank you, Hussein. And yeah, I thought this was a really interesting paper, really helpful. I just had a question on page 76 of the pack in Appendix A, and there's a comment in there around the challenges, which is saying that there's a lower uptake in urban settings than in rural settings. So if you said to me the uptake in Peter Cooter is much higher than in the city centre, I wouldn't be at all surprised. But I just wondered if that's kind of a completely universal thing, in that I'm just wondering if kind of the affluent West End has a better uptake or a worse uptake than some of the outlying areas.
Specifically with regard to city, I would have to go away and look at that specifically for you. If you're comparing the situation in Grampian with other areas of Scotland, it's always quite surprising when we look at it, because we obviously worry a lot about rurality and disadvantage from rurality. However, when we actually do sit down and analyse the figures, in Grampian at least, our uptake in rural areas is actually as good as our uptake in non-rural areas. If you want to ask me about specific parts of the city, I'm afraid I'd have to go away and look at the data for that.
My apologies, because even as I was asking that question, I was thinking that's the kind of question that I should have given you notice of. So apologies for that.
Thank you.
Yeah, I've just got a comment to add into that point, to answer John's point, to add to Claire's point. I think I would particularly highlight the transient nature of a city centre, the population. People who live within a mile a year or 2 miles a year move a lot, and the uptake relates to, you've had a letter, you haven't responded, it's a DNA, it's low uptake. I suspect there's much less of that transientness, if that's a word, John, in Peter Cooter than there is in city centre Aberdeen. So I think all cities have this major challenge. I can remember a few years back, we were getting in some parts of the city 2,000 letters coming back undelivered, not known at this address, in one morning kind of. So that tends to be a major challenge for cities. people move a lot and live in lots of different places, all within the city of Aberdeen, and the further out you get from the city centre, the less likely that becomes.
If I can just come in to that point, Chair. A couple of years ago, we did a targeted write out to try and improve MMR uptake, and we wrote out to parents of children who hadn't got those 2 MMRs recorded. And we got 10% of the letters that we sent out returned to sender, unknown at this address. So it's very likely that that number was actually that proportion was actually higher than that, because those are the ones who actually bothered to send the letter back. So that remains a problem. Thank you.
I will go to Sandy online.
Thank you very much, Hussein. I note that the annual report is, of course, for 24-25, and but a lot of the thinking and a lot of the discussion has been around more current thinking, and I think that's absolutely right. So my question really was around how do we translate a report like this, or the data in a report like this, to make it more accessible to people? And I'm sure that's done through marketing teams and so on, because social media is such a big tool for us in this day and age. But also to make the point, I guess, how much research is done into word of mouth, because it's certainly my experience that immunisation and vaccination are very much shared between peer groups, whether that's mums or generally older people. So that's really my first point stroke question. And secondly, it was to say on page 95, and maybe I'm getting this wrong. It says that that my second point was around populations, and of course I have a question around students and how they're dealt with in the programme, and that kind of reflects what people have been saying about inner city versus suburbs. And my third point was around shingles itself for the older population. It says on page 95 that it's offered to over 80s. I thought it was different. So maybe I could get an answer on that last point as well. Thank you.
Right. Shingles is, I'll start the opposite way around, if that's okay. Shingles is complicated because we're currently in the middle of a 10-year rollout of the shingles programme. So, and I think we're now in, I'm going to say year 3, it's around that. So basically with every year that goes by, we have an additional cohort to add to that. So the 80 pluses are the latest cohort to be added, but we're still vaccinating people as they become eligible for the 75s, and we're also expanding into people who are more vulnerable at a younger age than we previously had them as well. So this is it's a complicated programme, it's an evolving programme, and I'll be honest with you, I always have to go and look it up to see who's eligible this year. So I don't want to give you the wrong information by plucking figures out of the air. But the over 80s are a new part of that cohort. Students.
Just on that then, if I may
sorry?
intervene, Chair, just on that is such a complicated thing for people to understand, for ordinary people to understand. And, what I tend to get is that, people of my age, and I'm not quite 70, but, just don't understand that programme, if I'm being perfectly frank.
If I can come back, I'm extremely sorry to hear that, but I'm not at all surprised. The way we have implemented in Scotland compared to the way it was implemented in England is quite different. So in England, because it's a year-round programme, you become eligible as your birthday falls. In Scotland, because what we do is we have more of a campaign approach. So during the autumn and winter season, for example, we will only do autumn autumn and winter vaccinations, plus a small number of other things and the ongoing primary children's courses. And because of that, there are these rules about when your birthday falls and when you become eligible. And I'm sorry, it is very, very difficult to for people to understand. In fact, if you're not working in it daily, it is very difficult to understand. There are online tools to help you. You know, you can put your birthday in and it will tell you when you become eligible. But I completely agree with you. It is very complicated and it's very difficult to work with. And I'm afraid I don't have a good answer for how we do it better, other than nationally change how we're organising delivery of it. So apologies for that. I can see Joe Hall's hand's just gone up, so I don't know if this in relation to this, Joe.
Yeah, it is, and I think it is complex. And I think what we're finding at the moment, Sandra, is even when we're delivering 1 year to a programme. So for example, we started the RSV programme and we offered it to those turning 75, and then we did a catch up for those 75 to 79. And now what's happening now 1 year later is we're now, because of the effectiveness of the vaccine and the reduction in hospitalisation, what we're now finding is that cohort's now been expanded. So we're offering it to the 80s and overs. So I think in terms of the adult routine, we're not quite at a steady state in terms of the cohorts and who's being offered each of the vaccines. But I think it's a very valid point. And, you know, we'd had discussions around about putting in place almost a vaccination journey for adults, so you can see when you're being offered pneumococcal, when you're being offered shingles, when you're being offered RSV, and that's maybe something that we take away to develop based on the feedback here. Thanks.
Thank you. Should I quickly move on to universities? So universities, so a number of things happen. So we're in touch with the we're in touch with the universities throughout the year. It is the first thing, and we help them with what the information that they're putting on their websites and those kind of things. Chiefly, we ask them to, when they're writing out to students before they come to university, to ask them to get their vaccines before they come to university, because obviously when they get here, if we're then just starting to vaccinate them there, then there will be a period when they're at higher risk. So ideally we want to get them vaccinated before they arrive. Having said that, we do targeted vaccination clinics within the university environments. So we we particularly look at things like the meningitis ACWY vaccination. We can do that for students. We'll look at MMR for students, and we'll look at what else might be outstanding for them when if they have their information or we have their information, or and that we do that at Freshers Week, but then we also will go back throughout the year as well. Now, you may have heard about the meningitis B outbreak that happened in England a few weeks ago. As it happened, we actually had a planned clinic in one of the universities at the time that was happening, which was excellent timing because it got people thinking about vaccination, so they came forward. But unfortunately, meningitis B vaccine isn't one of the ones that we can offer currently to that age group. So it's something that's kind of going on in the background all the time. Work with students. I've left your first question to the end because I wanted a little bit of thinking time as I was talking about other things. We do use social media. The problems that we have with social media are that we tend, particularly for young people, we tend not to be on the platforms that young people use. So that's one issue why it's not as effective as it could be. The second is, even though we might have thousands of people following an account, it doesn't necessarily mean that all those thousands of people will get to see a message when it when it drops. And we're often asked by our communications colleagues, if you see something coming out of a you know, of a board or a partnership account, please can you like it, can you share it, can you can you do what you can do to amplify it so it has a better chance of getting out there. So we do have a lot of social media, and we do have a plan for social media and vaccinations through the Grampian account, and because all the communications people talk to each other, they do get amplified on other accounts. So we do use that. Is it as effective as we'd like it to be? Perhaps not. And it's how you get into those social media channels where you can get things amplified more easily. Word of mouth is really interesting too, and the only time we've looked at it, the only bit of evidence I can give you is we had a cardiovascular project running in the north of Aberdeenshire, and it was a very localized targeted project about people basically coming in and getting a pulse check and a blood pressure check in the vaccination centre for a 2-week period when we were running this as a trial. And a lot of the information was put out via local radio and local sources. What we found was the target audience was older people, but that wasn't how older people were getting to the clinics. What was happening was that their family were hearing these messages, picking up on them, and then saying, "Oh, have you heard about this? Maybe you ought to go down and do it." So that's the only time I can think of that we've actually looked at that word of mouth component, and that was almost by accident, because it became obvious that was how people were getting to us, not via the they weren't the primary receivers of the information that we were putting out. So it's an interesting question. So thank you for that.
Thanks for your answers. Thank you.
Going to Amanda next.
Thanks. I found the report really sort of interesting, and thanks, as I say, for putting it together. But the thing that I found really interesting was the fact that it sort of mentioned a lot, about how vaccines save lives. And I think we should just, really ram that home to people as much as possible. I'm sure you're doing that, but I just thought it was worth making the point.
No, thank you for that. What we've actually started doing in the last few months actually is, and this happened at the Area Clinical Forum, which colleague mentioned earlier. We've started taking a few slides at the beginning to say this is what the effect of a good vaccine program will be, and it gives the slide set has historical things like polio and iron lungs, and we don't see these anymore because of how good the polio vaccine program is, but also the newer ones like the RSV, which we already know is reducing hospitalizations by, well, depending on which paper you read, for adults between 60 odd and 80%, and around 80% for the youngest children. So that is something that we're starting to do more. And I'll be honest, at first I thought I did it for junior doctors first, but then I've started to use it more and more because it's been very well received as I've done it. So very happy, if at another occasion you'd like to see that kind of evidence, I'm very happy to bring that along on another occasion. Thank you.
Now come to Vicky. 2 quick questions, if I may. From your knowledge and experience, what are the barriers that are preventing Black Afro-Caribbean and Black British people coming forward for vaccination? From your knowledge and experience.
Okay, I might bring Caroline in on this again a little bit later. When we've spoken to, we did some work of probably about 3 years ago now with parents of children under the age of 6, and what what their kind of barriers were to vaccination for their children, and they seem to be, at least with regard to children, they seem to their concerns were similar to the kind of concerns we hear from other parts of the population too, and that was about side effects. That was about things like the MMR vaccine causing autism. It was things like sorry, I'm almost directly quoting here. The vaccines we have now aren't the same as the vaccines that we used to have, and that there seems to be some kind of perceived change between the kind of vaccination they would have when they were young to the kind of vaccination programs that children are involved with now. Maybe that's partially down to complexity, but also this was also post-COVID, and I think there is a feeling that vaccination is different in the post-COVID world as well. But I'll just ask Caroline if she has anything specific to add to that. But it is part of the work we're doing this year.
Yeah, I guess some of the work that we've been doing to try and help engage with some of these communities is we've engaged with places like Jesus Church and the King's Church, just to help us promote the importance of vaccines. And we've also arranged some local pop-up clinics at these churches as well. And I guess it's about having that trusted voice, you know, helping to promote the vaccines as well.
Thank you very much. My second question was, do you have an outreach program to refugee seekers and asylum seekers in the local hotels?
Caroline, do you want to come in? Because I know you've mentioned this a few minutes ago.
Yes, so we've been out to the local hotels to deliver vaccines, as well as holding local clinics here. And I spoke earlier about some of the work that we're doing jointly with our TB nurses as well. So yes, there's lots of outreach work going on with our asylum seekers.
Thank you.
Thank you. I am aware that general practices don't vaccinate. However, the report suggests that they do promote and advise individuals about vaccinations. However, as an unpaid carer, it's obviously very vital that I do have my vaccinations so that I can care for my loved one. I have not really had any input from my GP to promote vaccinations whenever I've gone myself to my own GP practice. And on top of that as well, as an unpaid carer, I don't even receive, you know, like a letter of you know, for appointments to go and get my vaccination. So I wondered if there was like a plan or future targeting for unpaid carers to make sure that they're not being missed out.
Okay, I think the first thing to say about unpaid carers is that we are bound by whatever the JCVI rules around eligibility for a programme are, and also the acceptance of that JCVI advice by the Scottish Government. And then we have, and then essentially we are given instructions on who we can vaccinate, who is eligible under a particular programme. And the eligibility for each programme is different, even to the extent that things like if you are, if you yourself had some, your immune system was suppressed because of some treatment or some disease or something like that, and you were eligible for one vaccination, that doesn't mean that you are eligible for another vaccination, even if it mentions being, having that immunosuppression, because each one is slightly different. And this is one of the complexities of the program. What this means in practice, that although for some conditions, household people in a vulnerable person's household, including carers, are eligible for some vaccines, it doesn't mean that they're eligible for all vaccines, and that it may be that the person you are caring for is eligible for a vaccination, but you yourself as their carer is not eligible for that same vaccination. I think picking up on earlier points about unpaid carers, then I think going on from the discussions today, maybe we need to have a look at what, clarifying that position of vaccinations and unpaid carers, and what programs they should expect to be called forward for, but equally, if it's not, there are other ones that they would not be called forward for. Would that kind of thing be helpful if we could work on something like that?
Yeah, I do think that would be helpful, because obviously you can be an unpaid carer at any age as well, so it could obviously span quite a large number of population too. So thank you.
Surely. And would it be okay if I contacted you directly?
Yeah, great, thank you.
Thank you.
Actually, on that point, just a wee point from me, and picking up on some of the comments that I think Sandra made as well. Joe, you mentioned in your answer almost a one-stop tool where you put in your date of birth and it shows you almost what your timeline should be. And that's the kind of vision I had in my mind for people who want to try and work out whether they are or are not in the pipeline or overdue or whatever it may be for vaccinations. I'm just thinking, as a broader point, if there are any links or resources that you feel would be helpful in trying to communicate that message further, I'm sure colleagues would be open to those being circulated to members. If you could maybe think about that and coordinate through Emma, if that's something you're happy to do.
Yeah, I'll come in on that. So yeah, no, more than happy. And I think the more the information is shared widely, just picking up on some of the points around about word of mouth, I think that would be absolutely beneficial. So yeah, we'll pick up that point round about the information around about carers. We'll pick up the information around about the adult routine program, and we'll try to develop some resources that would be meaningful and useful. Thank you.
Thank you. Guessing that takes us now to the recommendations on the paper, which are on page 69 and 70. And that is to note the findings of the NHS Grampian Vaccination Immunisation Annual Report 24-25, and also to instruct the Chief Officer to provide said report to the IJB with the next due in 2027. Are we happy to agree? Agreed. Yeah, thank you. Thank you to Joe, Claire, Albert, and Caroline as well for taking those questions. Much appreciated. 7.1 is the Aberdeen City Health and Social Care Partnership Work Plan 26-29 on pages 189 to 214 of the names of regulation. Our additional NMCs with this, and I ask Grace Stewart and anybody else who wishes to introduce and take us through the paper as a wish.
Thank you, Hussein. So we're delighted to present the new workforce plan to you today, and as you'll see from the plan itself, a lot of work has gone into getting us to where we are. In particular, there's been extensive consultation and engagement for this plan, taking feedback, direct feedback, from the external audit, from our workforce conference, and direct feedback from our senior leadership team. We also had a really good insight session last week with the IJB, where we were challenged to celebrate our successes more, quite rightly so. Like all partnerships, we have our challenges, as the data suggests, but we can reassure the IGB today that this is a plan built by our staff for our staff.
Our plan covers some of the data overview, as well as some pages showing what our teams deliver a month in the life of Team Aberdeen. Our services are experiencing higher complex and demand with competing resources issues such as finance, vacancies and absences. The plan sets out two plan priorities: staff health and wellbeing, and supporting staff to maximise integrations. Our priority actions include supporting retention, attendance and wellbeing, keeping us informed with information and engagement, training, support and collaboration, and finally, organising service delivery. These actions support our strategic delivery plan and focuses on the workforce wellbeing, training, support and people side of change, ensuring we bring our staff with us through transformation. Happy to take any questions.
Which Amanda first?
Thanks. Like you said, it's a brilliant report that this has happened, and I mean, I've mentioned this before, but I'm really glad that we're sort of really concentrating a lot on staff well-being, because I think if we can get that sorted, I think we might be able to sort of help with the tension and, you know, the recruitment sort of problems, if we can sort that out. And obviously in doing that, we can sort of, it would be better for patients and things like that if we can do that. So congratulations.
Thank you.
Thank you very much, Chair. Just looking at the performance measures, are we being challenging enough with regards to our mandatory training with a target of 70%?
So that's in line with NHS targets as well. So we've kind of trying to align alongside those. Probably we could take that a step further when it comes to our ACC side of our workforce as well. But with the complexity of the mandatory training and how we get that delivered, the set target is 70. So yeah, we could probably be a bit more ambitious, but I would like to start there and see how we get on with our standards for the next level.
Thank you. And Chair, if you wouldn't mind indulging me a little bit, I think with our focus on quality and how mandatory training fits in with that with regards to our staff, I think that stretch would be something that would be good to see.
Any others? No? Recommendations are on page 108 and 9. We're asked to approve the plan and also to instruct Chief Officer to schedule annual progress reports to the risk audit and performance committee. Are we happy to go? Great, thank you both for all the work that you've done, and in particular all the engagement work that goes behind this to make sure, as you've rightly said, we're not only doing this for our staff, but with our staff as well. 7.2 is the qualities out. Have you deliberately done this? Give you time to speak over here. 7.2 is the qualities, outcomes, and mainstreaming framework 2026-2030. Previous 250 improved 232. There are additional appendices with this, and possibly taking us through this, but Grace.
Yes, thank you very much. So thanks, Chair. The report currently sets out the refreshed equality outcomes for the partnership. The report sets out the linkages with our parent organisations outcomes as well, and there's been a lot of work in and that to support that outcomes too. Our 4 refreshed outcomes for the partnership are easy access for all, fair and inclusive care, equitable support for independent living, and services are planned in partnership with our communities. Our qualities outcomes have linked policy plans and strategies, and they're overseen by our Equality and Human Rights subgroup that's linked to our strategic planning group. And our plan would be to take an annual progress report to IGB annually. Again, happy to answer any questions.
Do you have any questions? Okay, I'm going to get hopelessly tongue-tied if I try and do this. So the recommendations are on page 216. Yeah, because I probably wouldn't take through those.
It's very integration type for A, proves the equalities outcomes mainstreaming framework 26. It instructs the chief officer to schedule and best reports. Joint board. The same instructs the chief officer to publish labor policies and
Thank you. Yeah, thank you for. Okay. 7.3 is the review of Balaghat County Care. There is an ethics NSB. I propose to deal with as many questions of members which to put in open session. Then to seek your pulse as to what we wish to do regarding the event. Is there any questions in that? That will determine on whether or not we take the decision either in public today or whether that is communicated to channels. But we now do turn on to the review of this, and that is in the additional circulation pages 69 through 104. I am pleased to invite Kate and Daniel to speak to this and make any additional comments as you wish.
Chair. Good afternoon. I'm Kate Simpson, Service Manager for Transformation, and I'm here today with Daniel Whiting, Service Manager for Care Homes, and we're presenting the paper on the review of Balaghat House Care Home. This report provides the Integration Joint Board with an update on the transfer of Donaghcord Care Services into Albion City Council and seeks approval for revised directions to reflect these arrangements. It also presents the outcome of a detailed review of services at Balaghat House Care Home, undertaken in response to declining demand for residential care, changing complexity of need, financial sustainability pressures, and ongoing regulatory requirements. Following consideration of the options appraisal, consultation feedback, and integrated impact assessments, the Chief Officer has determined that the service is no longer sustainable and that provision should cease. The Board is asked to note this decision alongside assurances that residents will be supported to move to appropriate care settings and that staff will be remobilised across the wider system to support service sustainability and delivery of strategic priorities. We appreciate that there's a lot of information within the paper, and we're very happy to take any questions.
By way of guidance, I would remind colleagues there are an additional 5, including the exempt appendix. Members will be aware of this, but for the interests of public awareness, I will stop you if you inadvertently tread into the exempt appendix. That having been said, does anyone have any comments or questions on this?
Yeah, hopefully I won't do that. But I think my sort of concern was I was looking at the comments made by the staff and the patients, which, as I say, obviously didn't go for option 2. But and I think that, but as I say, but having said which, as I say, then I've got to say with you was pretty clear as to why, and I obviously get all of that. But obviously, the only thing I would say is, if we do go for the option, I think it would be beneficial for the staff and the patients not able to be as less stressed as possible, in the transition.
Just, I will ask Kate to comment on that if she wishes, but just for absolute clarity to say that the decision has been taken in the delegated powers by the Chief Officer. But Kate, does that want to add?
Yeah, no, that's fine. I'll start and then Daniel can come in. Thank you, Amanda, for that point. What I would say is that Daniel and I and the team have been working very closely with residents, with families and with the staff, and we will continue to do that. The assurances have been provided. We are working jointly with them in terms of the transition planning, so we're very much taking them on that journey with us. Daniel,
yeah, just to add, Amanda, that so there's 11 service users, residents at Balaghat at the moment. Each one has identified social worker, care manager, and we've spoken at care homes and stuff. So we are aiming to do this. I think it's in the papers
by middle of August, over 13 weeks. So we will do it sensitively and individual wishes that we can.
Oh, thank you.
I was just curious to know, since there were 10 vacancies at Balnagas and 10 people on the waiting list for residential care, whether the hospital, whether the people were offered the opportunity to go to.
So yeah, when someone is assessed to need a care home, regardless of residential nursing, they will be given a list of suitable nursing homes or care homes, and that will depend on their individual needs and finances. Some are self-funding, also employed funding, and people can then choose which home they would like to go to. They may have, I think, there were inquiries around gas, but for one, no one has moved in. We do have vacancies in nearly all our residential care homes at the moment, so they would have been that choice, but we don't decide for people. We're giving guidance depending on their needs and wishes.
Thank you. Thanks, Mark, and I'll go to Brenda and David. Mark.
Thank you, Chair. I'm just coming back to 5.3 on workforce and the support around workforce. I think that's absolutely essential. To move the people from one place to another. I think pastoral support, I would like to associate myself with comments on that 5.3. I think it's very, very important that our staff feel valued as these decisions are made. I think that's just put that on record. Thank you, Chair.
Thank you, Mark.
It's just on that same point under 5.3, I can confirm that the trade unions have been involved with this decision, and the workforce have been given the opportunity to attend meetings regarding the updates on Balnagas.
And David, come to yourself online.
Thank you, Chair. My question is more general and regards whether there are additional similar homes being reviewed systematically, or whether this is a one-off case. Thank you.
One of the work streams that we are looking at doing is the review of care homes. So that is a piece of work that we are about to start. So we will be doing further review activity, and that should be in recognition of the declining demand for residential care, which you've seen in the report today. So we will be picking that up further.
Thank you.
To Martin, Richie, and I'll come back to you again. Martin?
Yes, thank you, Chair. I mean, I'm looking for an explanation to why the occupancy has declined from 20, so it's down to 11. So is it because of that reduced residential care demand? It would just be useful to get some more information on that.
Yeah, so that was really around the increased complexity of the residents that were there. A number of them were requiring nursing care level care, so they transferred to alternative nursing care provision, and that's a reduction in the numbers. And as we've heard, there hasn't been that uptake for alternative people moving in.
So is that number of 11 likely to continue to reduce?
It will reduce as people move on to the next care home.
Yeah, thanks. It's always a difficult opinion in motive decision to close any facility, any service. And I think just in terms of the paper we've got before is there's a whole range of factors that need to be taken into account. That Big rehearsed that really well. It's just acknowledge that. Question, and again, paper acknowledge this. I think in part, I just got complete assurance. In terms of the closing of this service, its impact on the whole system, if you like, just to get that assurance, this doesn't give us then a added pressure somewhere else across the system that might be unexpected or unhelpful in the system. Assurance about that rounded piece.
Yeah, we are confident that the impact will be minimal because the level of residential and care home vacancies we have. Certainly, I don't think about this. And the last year or the year before, we had Rotherham care home that closed with 40 beds, and that wasn't our decision. That was a care inspectorate decision, and the impact for care homes was minimal because we're seeing for one of the reasons people look at residential, want to stay at home longer, and stuff like that. So I'm not expecting to be an impact, but obviously that'll be monitored through a normal weekly monitoring with chief officer.
Thank you.
No, I'm good. No, I'm good. I'm dealt with. Thank you. Okay, Sandra.
Yeah, I just wanted to understand, and I didn't really pick it up from the report, or maybe I missed it, why there's such a flat line or a decreasing demand for care homes generally, but particularly the one that Balnagasc. I didn't really get that.
So I'm happy to come in there, Sandra, and Daniel come in and keep me right. So what we're seeing, the trend is that people are wanting to stay home for longer, and they're able to do that through technology-enabled care. So when people do need to go into a care setting, it's typically a nursing care home that they need rather than residential. So that's the trend that we're seeing, and we've been seeing that for some time now. Daniel, I don't know if you want to add anything.
Yeah, I think that's the main point, Sandra. I think the complexities of people's health and age when people decide to go to a care home is now a lot older, a lot more complexity of health, so they need that nursing support. With respect to residential care homes, and I've managed them and worked in them, then the level of needed aid support can now be supported in people's own homes, including very sheltered housing, with support community nurses and stuff as well. So we're finding that more people want to stay in those kind of facilities, as Kate says, rather than go to a care home where possibly if their health deteriorates further and they need the nursing support, they then have to move again. So it prevents further moves in the future.
Yeah, thank you for that. I haven't personally understood the drivers for that, whether it's you're driven by what is available to you because there isn't that thing in the middle. You either stay at home or you go into a nursing home, and so that I just haven't quite understood, and that's maybe yet if it's just because you can't have that option rather than it's an option that is available to people and they're just not taking it, if you get my drift. And it is, I suppose, moving a movable picture as well. I think my other question might be straying into the exempt part of the paper, so I'll leave it there.
Yeah, I just want to pick on something you said there, Sandra. I suppose what we're consistently hearing from people is that they want to stay at home for as long as they can. So that is typically the choices that people will be making. And obviously now with lots of developments that we've seen over recent years, that is now something that we can support. So people are typically staying at home for longer, and that's the choice that they're making. Thank you.
And just to maybe come back on that, Chair, that is all very well and good when you have unpaid carers to support you in that model, but it's not always the case that people can, because even with the best paid carers, it is often difficult for people to stay in their own home unless they've got family or friends that can support them to do it. And it sometimes comes down to what personal circumstances are, and for some people there just isn't the option to stay at home, but neither do they need full nursing facilities. So it's about keeping enough space in that middle ground, I guess, that does cater to the demand that I think will always be there for somebody that's not needing so much care, but also can't stay in their own home themselves.
I have a question, and that is there is a comment in the report around the carers, relatives, family of those who are moved to other locations and the support that they may need. And there is a comment about signposting them to third sector organisations. Given the strain on capacity that we know the third sector is facing, I was wondering if you could give us an assurance whether there have been any discussions with the organisation to give them a heads up that there may be some additional demand coming their way, whether it's now or whether it's to do with particular time of year, changing seasons, more difficult travel conditions, whatever it may be. Are those discussions that we've had just to keep our honest?
Yes, so they are. What I would say to that, Chair, is that through the discussions that Daniel and I have been having with family members, that hasn't actually been expressed by anybody as being a concern. So although we had referenced it in the integrated impact assessment as a potential impact, actually what we've heard is quite the opposite. There's been a couple of family members who have already expressed to us their preference for alternative care provisions, which would allow their loved ones to actually be closer travelling. So actually we've heard the opposite to what we anticipated might be a concern, which has been quite reassuring for us. But certainly there have been discussions, and when we were doing the consultation and engagement, we proactively reached out to advocacy, made sure there was advocacy care support available, should we publish, etc. But so far that's not actually been something that we anticipate being of concern or an issue.
I think my only comment to that would be, and I did note a comment in the paper that had not been expressed, but I think it's also probably just good practice and good courtesy just to make partners aware that even though there might not be an express need now, there may well be an express need in some way in the future. So it's something that could just be on their radar when it comes to being able to plan their own future resourcing to be able to deal with that. I do take your point made regarding the consultation list. With regard to dealing with the item, in terms of public awareness, I would make it known. I would simply say that, as has been stated, this is a decision that has been taken on the delegate. I will leave it at that. I'm keen that members have the opportunity to put questions as they wish, and I have no wish to be able to curtail that. And that being the case, we will conclude this item in executive session. Before we do that, my intention is to wrap up the public part of the meeting by moving to 9.1, and then dealing with any other business. And from there, we will move the recording and move on to all of the items of section 8. The official decision with respect to 7.3 will, as I said before, be communicated in the usual. But moving on to 9.1, which is the dates of future meetings, I intend to put only a single question on all of these. Does any member object? Therefore, the question is that the insight sessions take place on the 9th of June and the 14th of July 2026, and the next integration joint board take place on the 30th of June 2026. Are we happy to? Yeah, we are. Thank you. Regarding today's meeting, I just wanted to make a small point in response to item 6.3, responding to Vicky's question there. Term JVCI, the acronym rather JCVI, was mentioned. Just for public awareness, that stands for the Joint Committee on Vaccination and Immunisation, or the National Committee within the United Kingdom that determine eligibility for vaccinations. Just thought I would make that clear. In drawing to a close the public session, I want to take this opportunity to thank everyone for their interest, members for their scrutiny as always, which I think helps in our decision making, and also want to thank officers for not only the reports that they presented today, but all of the work that goes on behind the scenes in bringing them to this point. As always, I would ask you to please communicate our thanks and that of the LGB as a whole, and to your frontline teams and staff who do the work on the ground. That being said, I thank everyone for their contributions in the meeting. Thank you also to Emma for her stellar work as always. And I conclude the public part of this meeting until the 30th of June. That having been said, if you could bear with me just for